Now, this is about the X-ray role, but now when it comes to small bowel, enteroclysis is a better study than barium meal follow through. Why? Because how we do follow through, we give around 300 ml of barium and we take X-ray. First we take a X-ray for jejunal coils are specified. We wait for 15-20 minutes, half an hour. The contrast comes in. Ileum, and then we see ileum. Then we make oblique. We push a little bit. We palpate and we try to figure out the ileocecal junction. But this all becomes very passive. So what happens if a bowel is in peristalsis? You may confuse it for a stricture. Plus what happens in small bowel, we want to see mucosal aspect very well. And what is happening? You cannot see mucosal aspect very well because it is single contrast study. So what we do is we do this enteroclysis where we don't give barium to swallow. We push a nasogastric or orogastric tube actually, and the tube is long enough where the tip is at the jejunum proximal aspect. Special tube. It is called actually bibliodotter tube. With this bibliodotter tube, nasogastrically we go, tip is in the jejunum, and now dedicatedly we inject around 800 ml of barium. And it is not just barium, we also inject air. Air or methyl cellulose is better because air will come out. And how much air we will inject? So we inject a contrast agent called methyl cellulose. Barium, one contrast, carboxymethyl cellulose. Second contrast gives a wonderful bowel interface. Plus this carboxymethyl cellulose distends the bowel like air. Air is a contrast media. That is you should know that the most common contrast media used, otherwise double contrast media used is air. But air can be used in esophagus, maybe in stomach, but distal it is big enough, long enough, deep enough, we cannot. So use methyl cellulose. And that gives a very good interface. So what happens is enteroclysis is better because it is a double contrast study where we use barium sulfate around 800 ml plus carboxymethyl cellulose, making two things possible. One, excellent mucosal delineation plus proper assessment of bowel distensibility. You will not get confused peristalsis for stricture. Bowel distensibility. So that is why enteroclysis is better. A study for small bowel, and we are injecting by injecting a catheter. It is called as small bowel enema as well. Small bowel enema as well. We can similarly do CT enteroclysis. What you have to do? Give this oral contrast by catheter, fill up the small bowel, take CT sections, reconstruct. Even we can do MR enteroclysis. But the only thing is little difficult because of motion, but we do it. So because I'm telling you, because we had a question in PG Chandigarh 2013 June, which of the following studies can evaluate small bowel pathologies? And the options were enteroclysis, CT enteroclysis, MR enteroclysis, capsule endoscopy, and something. And a student mailed me saying, "Sir, is there something really called MR enteroclysis?" And then I told him, yeah, we do have, and we practically do it. And the advantage of MR and CT enteroclysis is we can see what is happening in the mucosa around the inside plus outside the bowel also. That's the advantage. Although resolution of this is better than the MR CT. Anyways, these are the things. Now, can you people tell me why is there need for enteroclysis? Special need for enteroclysis. Why do we have the need? We already have got the barium meal follow through, because I told you we want the advantage these two. And moreover, what happens, the pathology that affects small bowel are mucosal in origin. If you have observed, the pathologies are mucosal in the sense, try to recollect the pathology that affects small bowel. The most common pathology that affects small bowel are things like malabsorption, tropical sprue, celiac disease, tuberculosis, Crohn's disease, radiation enteritis, and mucosa, submucosa are affected. Which is endoscope possible? Endoscope can go up to stomach duodenum. Have you heard about scopy for small bowel? Almost not. Almost not, because we have heard about capsule endoscopy maybe, push enteroscope maybe. But we hardly have it in India. Only institutes like Premier, they have it, prime institutes. Dr. Nageshwar Reddy in Hyderabad, Asians of Gastroenterology, he has got it. But do you know who is Dr. Nageshwar Reddy? Dr. Nageshwar Reddy is almost called as father of gastroenterology. Father because like he is amazing gastroenterologist in Asia. Like if you people do MD medicine and if you do DM gastro, you will do ERCPs also, like ERCP, DM gastro people do it. And doing one ERCP in a week will be like wow, you will WhatsApp your friends. I did ERCP today. And this guy, Dr. Nageshwar Reddy, daily does 15 ERCPs, midnight up to 1 o'clock, 2 o'clock. So if at all we have this capsule endoscope, it is with this gentleman, very few in hospitals have it. Now think about endoscope, gastroscope, duodenoscope, every nook and corner has got it. So because we don't have very much availability, we have to have a way out, and barium, especially enteroclysis, helps us a lot. Okay, so this is how it helps. And now when you do these things, sometimes it helps enteroclysis in finding pathologies like what are the features of ileocecal TB. What features we get? Typically we get contracted cecum, because the TB bacilli, they affect the cecum. So you get contracted, pulled up cecum. Then what else we get? Widening of the ileocecal angle, widening of the IC angle. Then patulous valve, the valve becomes patulous valve, patulous ileocecal valve. Because it becomes a valve, when we view barium, you will see barium directly goes into the colon, rather because there is no cecum also now. So direct emptying of barium from terminal element to cecum is called Sterling sign, Sterlin, Sterling sign. So Sterling sign, patulous valve, widening of angle, contracted pulled up cecum, plus we get ulcers here, ulceronodular tuberculosis. So you get ileocecal ulcers. So these are the 5 features we get in ileocecal TB. Ileocecal area is most commonly affected area of GI tract in ileocecal TB. Crohn's. Now Crohn's is a disease. One more thing that we get is stricture. Tubercular strictures are common. Now Crohn's, Crohn's, Crohn's disease. It's an inflammatory bowel disease that can affect mouth to anus, any part of GIT, with most common being small bowel, especially terminal ileum most commonly affected. Crohn's, regional ileitis it is called, and it is characterized by small bowel ulcers. It is characterized by multiple strictures, with some of them resulting in the string sign of Cantor, means the area of stricture where the barium is gone, thin line is seen, barium going through stricturous part. String sign of Cantor. So you get small bowel ulcers, strictures, Crohn's disease. Plus it is a disease that is transmural. So the inflammation goes outside the bowel, resulting in adenopathy, mesenteric adenopathy. Plus if you do CT, you will see the bowel is thickened, thick walled small bowel, engorged vessels, and that is called comb sign. On CT we get comb sign because of the engorged vessels. Plus the inflammation is outside in the mesentery, so you get the fat which is inflamed here. That is giving appearance called as inflamed fat, creeping fat sign. Inflamed fat gives the appearance called creeping fat sign. And so remember, creeping fat sign, comb sign, mesentery is unclear because of inflammation. It's called misty mesentery. So misty mesentery, creeping fat, comb sign, string sign of Cantor, adenopathy, stricture, small bowel obstruction. And of course, these are the people who land up with, even because it is transmural, fistula. They develop fistulae also. Enterocutaneous fistulae. they'll end up with fistula. So radiology plays role in the sense of X-ray and barium enteroclysis in small bowel also plays a role in a pathology of small bowel, where actually speaking what helps is nuclear medicine. So what is that pathology? Is there any pathology of small bowel remaining where I'm giving you a hint? Nuclear medicine helps. Frequently suspected, often sought for, seldom found. What I am talking about? Frequently suspected, often sought for, seldom found. What is this? What I am talking about? Frequently suspected, often sought for, seldom found. These are the lines I am talking from Levin Bailey. Levin Bailey has given this aphorism. It is an aphorism which Charles Mayo said it. Levin Bailey has quoted it. Frequently suspected, often sought for, seldom found. इसको appendicitis नहीं है, इसको Meckel's diverticulitis होएगा. Frequently suspected. Then you go in, you remove appendix and you say अंदर आया ही हूँ, proximally Meckel से क्या देख लेता हूँ. Often sought for, often searched for, but seldom found. Rarely मिलता है, मिलता ही नहीं, क्योंकि rule of 2% तो incidence है. So what I am talking about? Frequently suspected, often sought for, seldom found is Meckel's diverticulum. And Meckel's diverticulum asymptomatic. But when symptomatic, when diverticulitis, they typically present with the GI bleed and the pain and all. And the most sensitive investigation is Meckel's scan. Meckel's scan is technetium pertectinate scan. What we do is, gamma camera is there, which is going to pick up the gamma uptake. We inject technetium 99 pertectinate. It goes and deposits selectively into the inflamed Meckel's diverticulum because it has got a ectopic gastric mucosa. It has got that ectopic gastric mucosa. So it picks it up, hotspot diagnostic. So what is the most sensitive investigation for Meckel's diverticulitis? Technetium pertectinate nuclear scan. Radiology helps. Okay, now comes last thing, small bowel tumors. Small bowel tumors. What is the investigation of choice? What is the investigation of choice? X-ray abdomen, nuclear scan, barium enteroclysis. What else? Fourth option is what? I don't remember, I think the fourth option. It was asked in AIMS recently, 14 or somewhere I guess. Investigation of choice for small bowel tumors. Enteroclysis, X-ray abdomen, ultrasound. X-ray abdomen is not the option. The options were ultrasound abdomen, enteroclysis, nuclear scan, and fourth option, I don't remember, I think. Answer is fourth, which I don't remember. The fourth option given was multi-slice contrast enhanced CT. CT is amazing because CT is something which can show you what is happening in the small bowel and outside the small bowel. It shows the enhancement pattern of the tumor, vascularity of the tumor. It tells you nature of the tumor. Is it a lipoma? Is it an adenoma? Is it a leiomyoma? Is it a that complex tumor which your Rajesh Khanna had in movie Anand? Lymphosarcoma of intestine. Whatever. CT is amazing for tumors. So for small bowel tumors, the investigation of choice is contrast enhanced CT because it tells you what is happening. If you do enteroclysis, you will see only a filling defect. If you do a nuclear scan, it will show uptake only in few cases of carcinoid. If you do CT, CT will tell you the tumor is here, enhancement pattern, invasion and nature probably. CT is the choice. Small bowel tumors. So CT is mainly done with two intentions. One is in bowel, small bowel partial small bowel obstruction, and second is suspected tumors. Suspected tumors. Now last is barium enema. Barium enema. Barium enema. Now barium enema, again, because of colonoscopy, because of contrast enhanced CT, not done. Rarely done. But yes, it still has got role. like it has a still role. Cecum, this is normal bowel. This is called as apple core appearance of bowel. Apple core. Apple core is typically seen with carcinoma of the colon. Apple पूरा खा लिया, core छोड़ा है सिर्फ, core बचा है. Malignancy does it. It eats up everything. Okay? Then the typical claw sign. Claw sign. Claw. You are pushing barium parectally. Barium is trying to go. Not able to go. Got stuck here as a claw. Why? Because the bowel has intercepted and gone from the cecum. The terminal ileum has gone from ascending into the transverse colon up to. Here edema develops. It cannot go beyond bowel to bowel, gets stuck. Telescoping of the proximal bowel into distal bowel interception. The one that goes in is interceptum, the one which receives is interceptions, and the one which takes these people in called leading point. And the most common leading point is hypertrophied Peyer's patch. And the most common age at which interception occurs is below 1 year of age. 6 months is the peak life, because that's the area where viral infections occur. And hypertrophied Peyer's patch takes these people in. The most common variety is ileocecal type, where you get the claw sign. Sometimes the barium that you push succeeds to go beyond little bit, and you get coating at the level of interception like this, called coil spring sign. Both signs have been described with interception called as coil spring sign and ये आपका claw sign. All said and done, nobody these days does barium enema for interception as a first choice. Ultrasound as investigation of choice. Barium is second line nowadays because barium involves a radiation dose. Ultrasound is free of ionizing radiation. One would argue that barium can be therapeutic as well. True. But even ultrasound can be therapeutic. How come? Do we push rectally that probe and push it out? No. Hydrostatic reduction. Ultrasound guided water reduction. Hydrostatic saline reduction. Okay. So we don't do barium. Ultrasound has become the choice. And when you do ultrasound, you get bowel in bowel, bowel in bowel, bowel in bowel, target sign on ultrasound. Target. Sometimes in a oblique plane, you get pseudo kidney sign. Pseudo kidney sign. Appearance also called as donut sign. Donut sign. These were asked in Chipmer, donut, pseudo kidney, target. Interception on ultrasound. On ultrasound. Interception. Okay? Barium. Barium. You have done barium, and barium is showing the very typical and characteristic sawtooth appearance on barium enema is seen in. Sawtooth appearance on barium enema is seen in diverticulitis. Diverticulosis, I mean. Colonic diverticulosis. Colonic diverticulosis. Okay, please remember, investigation of choice for diverticulosis is enema. But if it is inflamed, if it is diverticulitis or abscess, barium, scopia are contraindicated because there can be perforation. Contrast enhanced CT is the choice. Inflammation, because it will tell you about the bowel wall thickness, inflammation, surrounding abscess, infiltration, everything. CT is the choice without risk of perforation. CT is the choice. Amitabh Bachchan, if you know, he had diverticular disease of colon. I mean, he had diverticulitis in October 2012 approximately, I think. Yeah, they did his contrast CT abdomen in Lilavati Hospital, Mumbai. Why CT was done? Because it is investigation of choice. Okay, investigation of choice. Dilated colon, huge dilated colon, dilated colon, huge dilated colon, and then a zone of transition. So, where you get the typical proximal dilatation, constriction at the site of absent ganglionic cell. Absent ganglionic cells with zone of transition. Zone of transition seen in Hirschsprung's disease. Hirschsprung's disease. Okay, because a segment, short segment is most common, and what happens is here the cells are absent, ganglionic cells. So because there is absence of these cells, it constricts. It doesn't open up. Then there is zone of transition with proximal huge dilatation. Hirschsprung's disease. All said and done, the definitive investigation is rectal biopsy. Rectal biopsy. Okay, rectal biopsy. What are we talking about? See the colon. I mean, how can a colon be so bland without hostrations? No hostrations. How come there are no hostrations? No hostrations, I mean, how come? Hostra are lost because of the inflammation. So see now, the earliest feature we get on barium enema in ulcerative colitis is mucosal granularity. Earliest feature, mucosal granularity. Second feature is loss of hostrations. Loss of hostration. Third, ulcers develop. Collar button, aphthous, aphthoid, ulcers develop. Fourth feature, these ulcers in between heel and the mucosa pops up, giving rise to pseudopolyps. And last, these people try to heal, the colon becomes stiff, resulting in lead pipe colon, and sometimes the inflammation ascends and it goes into the small bowel called as backwash ileitis. And few of the people may develop rare colonic cancer. Few of the people may develop uncommon, rare colonic cancer. And let us remember, UC is a disease which is limited to mucosa and submucosa. Okay, now last pathology where barium enema is useful is sigmoid volvulus. Volvulus means twisting of colon itself. The most common part of GIT to undergo twist is sigmoid. And what you get on X-ray is see the twist. Because the twist, the bowel is obstructed like this. So what you get? See, this is the inner loop of bowel, outer loop of the bowel, level of obstruction, resulting in appearance called as, see, how is this looking? This is called, how is it? It is looking, this is called as, how is it looking? Coffee bean sign. Is it not looking like coffee bean? You have to say it is looking like coffee bean because it is called coffee bean sign. No jokes apart, I mean, this is coffee bean sign. Bent inner tube sign. See, bent inner tube sign. Inverted U sign, this outer aspect, inverted U. Third sign, inverted U sign. Fourth, normally the colon doesn't go so up. If it goes up and overlaps liver, normally it should be up to here maybe. Liver overlap sign. Fifth sign, normally the colon doesn't reach up to so high level of vertebrae. It is, if it reaches up to D10 overlap sign. D10 overlap sign. Flank overlap sign. Liver overlap sign. Coffee bean sign. Inert, bent inner tube sign. ये bent inner tube and inverted U together makes a called omega sign also. Omega sign. Your favorite book, SRB Manual of Surgery, has given it. I mean, although 11 Bill is an amazing book, but still people like the SRB. Okay, now if you do barium enema in these cases, it is very helpful. And then what you see, you are trying to push barium at the level of twist. The barium tries to go, and here you see the opacified with a narrowing here, opacified loop with a narrowing at the level of twist. Barium somehow manages to go, opacifies, giving bird of prey sign or bird beak sign. Bird beak of bird or prey, bird of prey, BRD, of prey, PREY, prey sign. Okay.